Welcome back to the deep dive. Today, we are undertaking a systematic investigation into the one constant that connects all of us,
Yeah.
the inevitable physical landscape of aging.
Mm-hmm.
We're diving into biosocial development in adulthood, and we're asking a crucial sort of two-part question. How much of the body's slowdown is strictly predetermined by our genetics?
And on the other hand, how much of it can we actually control or, maybe postpone through our lifestyle choices?
Exactly.
It's a deep dive into senescence, which is, the technical term for this highly systematic, age-related physical decline that, and this is the key, begins far earlier than most of us realize.
Right.
We're moving past the general assumptions about, just getting older, and we're getting into the actual metrics, the timelines, and the biological why behind it all.
And our source material for this deep dive is, well, it's really robust. It gives us a precise breakdown of this physical decline across the entire adult lifespan.
It does.
We're pulling out very specific data points today. We're covering everything from, say, the 1% annual loss of skin collagen to some really stark data showing how your socioeconomic status can drastically alter your mortality risk.
So our mission today is crystal clear. We want to extract those measurable metrics and timelines of physical decline.
The takeaways.
The key takeaways. You should walk away from this with a much clearer understanding of the engine under the hood, so to speak, knowing not just that the body changes, but when those changes actually start, how they progress, and maybe most importantly, where you hold the most control.
Okay, so before we jump into the specific systems, let's frame this whole conversation with two foundational truths that the research really emphasizes.
Yes, this is a great place to start. The first truth is that aging is a gradual, universal physical decline. It affects every organ, every system, every single cell. It is, simply put, unavoidable.
And the second truth.
The second, and I think this is the more empowering truth, is that this process involves both genetic mandates and profound environmental and lifestyle influences.
So nature and nurture.
Classic nature and nurture. While the decline itself is universal, the rate and the consequences of that decline are highly variable, and not just between different people, but even within a single body. I mean, one person's kidneys might age faster than their heart, and lifestyle is really the major lever there.
That's a fascinating way to put it. Let's get into it. Okay, so let's start beneath the surface, where this systemic slowdown begins long before we actually feel it. The source material confirms that every system, skeletal, cardiovascular, respiratory, is already losing efficiency in early adulthood.
That's right. And one of the most critical yet frequently silent indicators of this systemic slowdown is blood pressure.
The silent killer.
Well, that's what they call it. The fact is that blood pressure increases with age, and this is primarily driven by the stiffening and the decreased elasticity of the major arterial walls.
We hear about hypertension all the time, but break that down for us. Why is this specific age-related increase so central to our overall health risk?
Well, because it's a constant, measurable strain on the entire cardiovascular system. Think about it like this. As we age, our arteries lose their ability to sort of stretch and accommodate the blood being pumped by the heart.
They get less flexible.
Exactly. They become more rigid. And that forces the heart to work harder with every single beat just to push the blood through. This particularly affects the systolic blood pressure, that's the pop number in a reading, which measures the pressure when the heart actually beats.
So that number tends to creep up more over time.
It often rises more dramatically than the diastolic, the bottom number. And controlling that systolic pressure becomes absolutely essential as we get older.
So the consequence isn't just about, a high number on a chart at the doctor's office. It's about the constant day in, day out wear and tear that this high pressure creates.
Precisely. Chronic hypertension accelerates atherosclerosis, which is the hardening of the arteries. It damages the very delicate filtering units in the kidneys, which can lead to chronic kidney disease. And of course, it dramatically escalates the risk of both kinds of strokes, ischemic and hemorrhagic.
Wow.
It's really the single most controllable factor that determines your overall vascular health. And that's why prevention through diet, sodium restriction, exercise is so paramount.
Okay, shifting to another internal process, let's talk about breathing function and this fundamental concept of homeostasis.
Right. Homeostasis is the body's highly sophisticated internal balancing act. It's the ability to maintain a stable core temperature, proper blood pH, consistent blood sugar levels, despite what the external environment is throwing at us.
Like when you go from a cold room to a hot one.
That's a perfect example. It's how your body responds when you go from that cold outdoor environment into a hot, humid one, or even when you're just fighting off a minor cold. It's your body's thermostat and regulator all in one.
And in youth, that regulatory system is like lightning fast. It brings us back to our baseline really quickly. What happens to that system as we age?
The sources explain that the homeostatic response just becomes slower and less efficient. If you
Yeah.
get too hot, your older body takes longer to activate the necessary cooling mechanisms like sweating. If you take a medication, the drug metabolism and clearance might be slower.
So everything is just a bit delayed.
Exactly. This reduced efficiency, combined with the fact that your maximum breathing function decreases as your lung elasticity diminishes, while it significantly increases our vulnerability to illness and to environmental stress of any kind.
And I think it's important to stress our sources are very clear that this decline doesn't happen at the same pace for everyone.
Oh, absolutely not. While some slowing is universal, the acceleration factors are, lifestyle 101.
The usual suspects.
The usual suspects: smoking, which just dramatically reduces lung capacity and elasticity; poor eating habits, which create chronic inflammation throughout the body; a lack of exercise, which limits your cardiovascular reserve; and maybe the most subtle one, chronic stress.
How does stress play into it?
Chronic stress keeps the body in a constant state of low-grade emergency. The fight-or-flight response is always simmering, and that just exhausts those homeostatic reserves over time.
Okay, let's move from the inside to the outside. The physical signs that become apparent to the world. We're talking about the systematic changes in appearance, and the timeline here is, frankly, startlingly early. It all seems to hinge on what the sources call the collagen clock.
This is one of the most memorable data points in the entire deep dive, I think. Collagen is the primary structural protein in the skin. It provides its firmness, its elasticity, its bounce, if you will.
Right.
And the research shows it decreases by approximately 1% per year,
1% per year.
starting right around age 20.
Age 20, that's just incredible. So that physical decline is underway almost before your typical adult life has even really started.
Correct. That 1% annual loss is the core mechanism of what we call intrinsic aging. It means the dermal layer of your skin is slowly thinning and weakening from the inside out. We don't see the effects immediately, of course, but that steady decline is what dictates the physical milestones later on.
So walk us through those skin milestones then, the ones tied to this collagen clock.
Okay. By age 30, the cumulative loss, that's a decade of 1% per year, means the skin is noticeably thinner and less flexible than it was. This is when fine lines and wrinkles start to become visible.
Especially around the eyes and mouth.
Exactly, areas of high movement. The skin also starts to lose some of its ability to retain moisture as effectively.
And then, as that 1% loss just keeps ticking away over time.
By age 40, we see the next progression. You get the appearance of what we commonly call age spots, which are just areas of increased melanin production. Tiny blood vessels might become more visible, and you just get a general shift in skin texture and color. This is the accumulated result of that 2-decade-long decline.
And I assume that's accelerated by things like sun exposure.
Oh, massively. Extrinsic factors like sun exposure and smoking are huge accelerators. They directly degrade the collagen structures you already have, so you're getting hit from both sides.
Okay, moving beyond the skin, let's discuss hair, overall body shape, and the agility timelines.
The hair changes are pretty predictable, as you'd imagine. We see a reduction in melanin, which causes graying, and a thinning of the hair shaft itself. Interestingly, while the hair on your head thins, body hair also tends to become less dense overall.
Which is probably a hormonal shift.
It's largely a hormonal shift. And then, of course, there's the dreaded shift in body shape, the middle-age spread.
A near universal experience, it seems.
It really is. Your metabolism slows down, and adults gain an average of 20 pounds between the ages of 25 and 60.
And it tends to gather around the middle.
It often centralizes that fat distribution right around the abdomen.
Wow.
And at the same time, we see muscle weakening. There's a process called sarcopenia, which is the age-related loss of muscle mass and strength. The sources note that these significant body shape changes become statistically evident by age 50.
We also start losing height in late middle age. Is that just the spine compressing?
It's a combination of things, but yes, the compression of the intervertebral discs is a key part of it, along with changes in posture. And crucially, your joints lose flexibility.
How does that happen?
Your ligaments and tendons, they just become less elastic. It's due to changes in their own collagen and elastin composition. That reduced elasticity means reduced agility, reduced mobility. It
Hmm.
makes certain movements, like a fast rotation or a deep stretch, more difficult and, frankly, higher risk for injury.
This all sounds like a biological mandate, but let's circle back to that variability you mentioned. If this collagen clock is universal, how much difference can lifestyle really make?
A huge difference. The sources really emphasize this. Your genes and your exercise habits cause significant variations in all of these markers.
So genes set the starting point.
Genes dictate the quality of your collagen to begin with, yes. But your lifestyle avoiding UV damage, not smoking, regular strength training, directly counteracts the acceleration of that decline. Exercise specifically mitigates sarcopenia and maintains joint lubrication. This means you might hit 60 with the agility markers of a 45-year-old.
So the decline is still happening.
The decline is happening, but the slope of the curve is negotiable.
Now we move to our senses. As the internal machinery slows, our interface with the external world starts to change. Let's start with vision, where the changes are often subtle, but really profound.
Yes, the visual system is incredibly complex, and the sources highlight changes that go way beyond just simple focusing issues. For example, your peripheral vision narrows faster than your frontal vision.
So you lose the edges first.
You lose awareness of objects at the edge of your sight first, which has huge implications for tasks that require situational awareness, like driving.
And that's a shrinking visual field that we often don't even notice until it becomes a real problem.
Exactly. Furthermore, your color vision tends to shift. Colors can appear less vivid, maybe a bit faded, and that's a change that occurs more quickly than the loss of simple black and white contrast.
And the one that drives everyone crazy, adjusting to the dark.
The adjustment to darkness, yes. The time it takes for your eyes to adapt when you move from a brightly lit area to a dark one, it's called dark adaptation, increases significantly. And that's because of the cumulative degradation of the rods and cones in your retina. Hashtag tag vision and here.
Let's tackle the famous shift in focus, the sudden need for reading glasses. The sources present a really fascinating mechanism that explains why so many older adults are often both nearsighted and farsighted.
This is absolutely key to understanding adult vision. Nearsightedness or myopia, that's difficulty seeing distant objects, that often increases gradually starting in the 20s as the eyeball shape might change slightly.
Yeah.
But the main event in middle age is farsightedness, which is known as presbyopia.
And what's the mechanism that causes that middle-age farsightedness?
It happens because the lens of the eye loses its elasticity. You have these things called ciliary muscles, which contract to change the shape of the lens for you to focus up close. They struggle to operate effectively when the lens itself becomes harder and flatter with age.
So the muscle's working, but the lens won't cooperate.
That's it. That loss of elasticity means close objects just can't be brought into sharp focus anymore.
So if you are already nearsighted, you still have that original shape issue causing distance problems, but now you also have this lens elasticity issue causing close-up problems.
And that's the crucial point. Younger adults are typically one or the other, but most older adults eventually become both. You need one corrective measure to help your flattened cornea and inelastic lens focus on near objects, and another to compensate for any existing myopia that's impacting your distance vision.
And that's why we have bifocals.
That is exactly why bifocals, trifocals, or progressive lenses become necessary.
Okay, moving to hearing loss. The term is presbycusis.
Presbycusis, yes. It's the clinical term for the loss of hearing associated specifically with senescence, with aging. It's a progressive bilateral loss, which means it affects both ears about equally.
And what does this sound like, or not sound like?
It's typically characterized by difficulty in hearing high-frequency sounds. This is what makes speech comprehension in noisy environments so challenging. You can hear that people are talking, but you can't quite make out the words because the crisp, high-frequency consonant sounds get lost.
And when does this decline typically manifest into noticeable problems for most people?
It generally doesn't become subjectively apparent until after age 60. However, and this is a huge however, the source material explicitly stresses the impact of environmental factors.
Like loud noise.
Exactly. Damage to the delicate hair cells in the cochlea, which are what transmit sound from sustained exposure to loud music, construction noise, or prolonged use of earphones at high volume, is accelerating this timeline.
So we have an entire cohort of people now entering middle age who might experience the symptoms of presbycusis years or maybe even a decade before that historical benchmark of age 60.
Precisely. We are seeing a compression of the typical aging timeline for hearing, and it's almost entirely due to the pervasive nature of noise in modern life. It really highlights that biosocial development is always a consequence of biological limits interacting with the environment we live in. Hashtag B, the respiratory system under pressure.
Let's circle back to the internal systems for a minute and discuss the respiratory system,
Hmm.
because the quantification of its decline is one of the most sobering data sets that we have.
It really is. The sources provide a very clear quantification. The lungs just become less efficient with age. And the key metric here is the reduction in oxygen capacity.
How much does it reduce by?
It's measurably reduced by between 2 and 12% per decade.
Per decade.
Per decade. And that wide range depends heavily on things like body size and, most significantly, on habits like smoking.
That reduction means that for every 10 years we live, the max amount of oxygen our body can process takes a pretty significant hit.
A huge hit. And that inefficiency is rooted in physical change. The tissues in the alveoli, those are the tiny air sacs where the gas exchange happens. They lose their elasticity. The bronchial tubes lose some of their stiffness. It makes a full inspiration and expiration harder to achieve.
And that directly impacts your ability to handle physical exertion.
And critically, to fight off infection.
Which brings us to a tragic demonstration of this cumulative decline, which was exposed during the COVID-19 pandemic. We have a specific data point that just hammers home the vulnerability of compromised lungs.
It's a devastating statistic. The sources cite that obese smokers had almost twice the death rate during COVID-19, even when they were placed on mechanical ventilation.
Twice the death rate, even with maximum medical intervention.
Yes. This isn't just a simple risk increase, it's a catastrophic vulnerability.
And why is that specific combination, obesity and smoking, so lethal? What's the mechanism?
Well, both factors degrade the body's reserves in unique ways that just compound the respiratory insult. Smoking, as we know, directly compromises lung function and reduces oxygen capacity. That's a given.
Right.
Obesity, on the other hand, creates a state of chronic systemic inflammation.
Right.
And the excess weight physically restricts the movement of the diaphragm and the chest wall, making it harder to take a deep breath in the first place.
So when a virus like COVID-19 hits,
When an acute pathogen like COVID-19 hits, the lungs are already operating at a drastically reduced capacity, and the body's inflammatory response is already hyperstimulated. They just had no reserve left to fight the virus, even with maximum medical support. It's an incredibly powerful illustration of the long-term cost of lifestyle choices.
moving now to a sensitive but a crucial area of development, the sexual reproductive system. The physical changes here are pretty well known, but the psychological overlay is perhaps even more important. What are the objective physical realities regarding responsiveness?
Physically, the process just slows down for both sexes. Sexual arousal occurs more slowly, and that's due to a reduced vascular response and some subtle shifts in hormones. Consequently, orgasm takes longer to achieve with age. These are, biological realities tied to that gradual systemic slowdown we've already been discussing. Hashtag A responsiveness and satisfaction.
But here's what I think is the aha moment from the psychological research we have. The distress related to those biological slowdowns is often not purely biological.
That's the critical distinction. The sources really emphasize that distress over slower responsiveness. For example, a man experiencing a delayed erection or a woman experiencing reduced lubrication is often more strongly correlated with anxiety, with performance expectations, and with the quality of the interpersonal relationship than it is with the objective physical aging process itself.
So our self-perception and how we communicate within a relationship can be a bigger barrier to satisfaction than the actual flow of blood or hormones.
Exactly. I mean, if an individual internalizes that slower response as a failure or as a sign of lost desirability, the anxiety itself creates a powerful psychological barrier that only exacerbates the problem.
A self-fulfilling prophecy.
In many ways, yes. And conversely, the research finds that adults of all ages report high levels of sexual satisfaction, especially within committed monogamous relationships, where communication, intimacy, and a focus on mutual satisfaction tend to override any of these minor physical slowdowns.
So it's quality over velocity, effectively?
That is a perfect summary. Hashtag B, fertility, infertility, and causes.
Okay, now let's look at the statistics around infertility. A definition that can vary a bit, but generally means a couple is struggling to conceive.
The standard definition of infertility is the inability to conceive after trying for at least 1 year. Globally, it remains most common in regions where medical care is scarce and significantly where sexually transmitted infections, or STIs, are prevalent,
Why STIs in particular?
because they can cause significant and often silent damage to the reproductive tract that isn't discovered until years later when a couple tries to conceive.
And what does the picture look like in the United States?
The sources show that about 12% of all couples in the U.S. are infertile. And a significant driver of this rate is the social trend of postponing childbearing until later in life.
The risk really accelerates with age, doesn't it?
It accelerates rapidly. Half of those trying to conceive in their 40s are infertile, and the other half face elevated risks of complications, including miscarriage and birth defects, primarily because the quality of the ova declines significantly with age.
Let's break down the complex factors that cause infertility, starting with the male causes.
Sure, male fertility is generally measured by three things: sperm quantity, morphology, which is its shape, and motility, which is its movement. These factors can all be reduced by advanced age, but also acutely by exposures like a high fever or radiation.
And lifestyle.
Lifestyle factors are huge culprits: prescription drugs, chronic stress, environmental toxins, and of course, abuse of drugs, alcohol, or cigarettes. These all can reduce the total number and the functional capability of the sperm.
And what about the factors affecting female fertility?
For women, female fertility is primarily affected by advanced age, which reduces both the quantity and the quality of her ova. But systemic issues like other diseases, smoking, extreme dieting, and obesity all impair the hormonal environment that's necessary for conception.
And our sources highlight one specific cause, pelvic inflammatory disease, or PID.
Yes.
How does PID cause infertility?
PID is often caused by untreated STIs, like chlamydia or gonorrhea. It creates scarring and inflammation in the reproductive organs. This physical damage can actually block the fallopian tubes, which prevents the sperm from ever reaching the ovum, or it could block a fertilized egg from descending into the uterus, which can lead to an ectopic pregnancy or infertility. Hashtag C, assisted reproductive technology, RT.
Thankfully, advances in medicine have provided a lot of solutions through assisted reproductive technology, or RT. What's the general success rate here?
RT has dramatically shifted the landscape. It successfully solves about half of all fertility problems. It's designed to effectively bypass physical obstacles like a low sperm count or blocked fallopian tubes.
Let's detail the most common procedure, in vitro fertilization, or IVF, as it's outlined in our sources.
Okay, so IVF is a multi-step process. First, the woman undergoes hormonal stimulation to produce multiple ova or eggs at once. Those ova are then surgically retrieved.
And the fertilization happens outside the body.
That's the in vitro part. It means in glass. They're fertilized with sperm in a laboratory dish. Once fertilization occurs and the resulting zygotes have divided successfully to an early embryo stage, they are then carefully inserted directly into the woman's uterus for potential implantation.
The sources also touched on a profoundly important ethical and public health application of art regarding HIV-positive adults. How are protective measures implemented in this highly sensitive area?
This is one of the great triumphs of modern RT. If the woman is HIV positive, the risk to the fetus is managed through powerful antiviral drugs that are given throughout the pregnancy. And that's often combined with a scheduled cesarean section to minimize any exposure during delivery.
And what if the man is HIV positive?
This is where the technology is particularly protective and quite brilliant. The man's sperm is collected, and then a technique called sperm washing is performed.
What does that entail?
It's an intensive washing process that separates the sperm cells themselves from the seminal fluid, which is where the HIV virus actually resides. The washed, virus-free sperm is then used in the IVF procedure.
And that's safer than natural conception.
The sources note that this method is considerably safer even if the HIV-positive partner is on virus-suppressing drugs. It offers a near-zero risk of viral transmission.
Transitioning now into middle age, we confront two major hormonal shifts: menopause for women and andropause for men. Let's start with menopause.
Menopause is the official point when menstrual periods cease completely. The process leading up to it, perimenopause, is gradual, but the average age of that final cessation, as defined by our sources, is 51.
And biologically, what is the core change that's happening?
It is a significant and relatively sudden drop in the production of three key sex hormones: estrogen, progesterone, and to a lesser extent, testosterone. This hormonal collapse is what drives most of the physical symptoms.
How is it officially dated?
The official dating of menopause is purely retrospective. It's defined as 1 full year after a woman's last menstrual period.
Is the timing of it random? Or is it heavily dictated by our biology?
It's profoundly biological. The sources indicate that 17 specific genes have been identified as primary influencers on the timing of menopause. So if your mother or sisters experienced it early or late, you're highly likely to follow a similar timeline.
And we noted earlier that the psychological consequences of this vary so widely, even if the biological mechanism is fixed.
Absolutely. While things like hot flashes and physical changes are predictable, the psychological experience, feelings of loss, relief, distress, or indifference, varies far more than the physical symptoms. And that variation is tied to cultural views on aging, the woman's personal identity, and her social support structure.
This leads us to hormone replacement therapy, or HRT, a treatment that has seen decades of debate regarding its benefits versus its risks.
HRT is designed to compensate for that reduction in estrogen and progesterone. And the benefits can be substantial and immediate for many women. It minimizes the acute symptoms of menopause, particularly the severity and frequency of hot flashes.
And it has long-term benefits too, right?
Crucially, yes. It significantly diminishes the long-term risk of osteoporosis, which is a massive concern in later adulthood, by helping to maintain bone density.
But the risks are why this is not a universal solution for everyone.
The risks, which were famously highlighted by large studies like the Women's Health Initiative, are clear and serious. HRT, especially if it's used for a long time, has been linked to increased risks of cardiovascular issues, including heart disease and stroke, and an elevated risk for certain types of cancer, particularly breast cancer.
So it's a trade-off.
It's a classic risk-benefit calculation that has to be done on an individualized basis, based on a woman's family history and her personal health profile.
Finally, what about the male experience, which is often termed andropause?
Andropause is the term that was coined to signify a noticeable, though typically much more gradual, drop in testosterone levels in older men. Unlike the sudden cessation in women, this is a slow decline that occurs over decades.
And what are the consequences?
The consequences can include a reduction in sexual desire, fewer strong erections, and an observable loss of muscle mass and bone density.
Is the corresponding male hormone replacement therapy equally effective or common?
The sources are much more cautious here. While testosterone replacement is available, the effectiveness of HRT for men in managing long-term health is, frankly, questionable. It requires much more extensive research, particularly regarding potential cardiovascular side effects. It's not considered a preventative measure for major age-related disease in the same established way that estrogen therapy can be for osteoporosis.
As adults navigate this physical landscape, their reliance on external chemistry medications, substances, supplements, it becomes pretty central to managing health and well-being.
Yes, and we have some very concrete data from the U.S., specifically from 2013-2014, that tracks the sharp rise in prescription drug usage across the adult lifespan. This tells a powerful story about the onset of chronic conditions. ### group prescription and over-the-counter drug use.
Let's look at that usage snapshot. We see a massive jump in reliance right at the start of middle age.
A staggering difference. For 18 to 44-year-olds, 64% took no prescription drugs in 1 month.
So about 2/3 of younger adults.
Right. Contrast that with 45 to 64-year-olds, where only 31% took no prescription drugs. That means 2/3 of middle-aged adults are relying on at least one prescription drug every single month.
And that signals the transition from, say, purely preventative health to chronic disease management.
Exactly. And the prevalence of psychoactive medications is also quite high. Antidepressants are a good example.
What does the data show there?
The data shows that 1 in every 11 adults younger than 45 takes antidepressants daily. That reflects the mental health challenges faced by young adults, but that number increases to 1 in 5 older adults.
1 in 5. That's huge.
It is. It signals the accumulated impact of stress, loss, and the chronic pain that often accompanies later life.
And that data doesn't even cover the enormous consumption of over-the-counter drugs.
Not at all. Virtually every adult relies on over-the-counter medication at some point. Of vitamins, analgesics like painkillers, antihistamines, supplements, you name it. This just underscores a modern reality. Medication, in its broadest sense, is now inextricably linked to maintaining health and vitality in adulthood. And the sources do affirm that medical progress, from type 1 diabetes management to psychological health improvements, is largely driven by these pharmaceutical advances. #HAB, the opioid crisis, and age demographics.
Now, we have to turn to the devastating crisis that's impacting millions. Opioid use and overdose deaths.
The opioid crisis really highlights the deep physiological reliance that develops with these medications. The sources note that patients using opioids find the withdrawal process intensely painful, which is a major physiological barrier to cessation and recovery. This physical dependence makes it incredibly difficult to break the cycle.
And the isolation and upheaval caused by the COVID-19 pandemic acted as a tragic accelerant to this crisis.
It absolutely did. The pandemic disrupted support systems, it eliminated in-person treatment access for many people, and it dramatically increased stress and isolation. The consequence was a shocking 41% increase in opioid overdose deaths in the United States in just 1 year from 2019.
41%?
In a single year. And the demographic detail here is crucial for our deep dive into adulthood development. We have to ask who was hit hardest.
What did the sources say?
The largest increase in overdose deaths was specifically concentrated among 35 to 44-year-olds. This is a demographic that is often juggling peak career demands, financial stress, childcare responsibilities, aging parents.
The sandwich generation.
Exactly. The confluence of that acute pandemic-related stress and reduced access to care just pushed this group into the highest vulnerability category for fatal outcomes.
Okay, switching to socially accepted psychoactive drugs. Let's start with tobacco.
Tobacco remains the leading behavioral risk factor for a massive array of diseases. Cancer, heart disease, stroke, respiratory illness. It's just a killer. However, we do have a positive public health success story here.
Which is?
The significant reductions in U.S. smoking rates over the last few decades are now clearly reflected in population health outcomes. Specifically, we're seeing significantly reduced lung cancer deaths for both men and women.
So it's a direct correlation.
It's a direct correlation that demonstrates the powerful, large-scale impact that changing one specific behavior can have on the entire trajectory of biosocial decline.
Finally, alcohol. This brings us back to what you call the fascinating moderation paradox, where the sources suggest that controlled consumption can actually be beneficial.
This is one area where the nuance is absolutely essential. The sources define moderation very specifically: no more than 2 drinks per day. At this level, population studies suggest it can slightly increase life expectancy.
How does that level of moderation translate into tangible physical benefits? What's it doing?
It's primarily through cardiovascular benefits. Moderate alcohol consumption is associated with a reduced risk of coronary heart disease and strokes. Biologically, it seems to work by increasing levels of HDL, which is the good cholesterol, which in turn helps clear LDL, the bad cholesterol, from the arteries.
And it has other effects.
It has a minor anti-clotting effect, and it can contribute to slightly lowered blood pressure.
So, controlled use can support the vascular system, but the harm of exceeding that limit is widespread and severe.
Oh, the harm is immediate and cumulative. Excess alcohol consumption destroys brain cells, leading to cognitive impairment and long-term conditions like Wernicke-Korsakoff syndrome. It causes severe liver damage, leading to cirrhosis and liver failure. And it contributes to an increased risk of several cancers.
So the line between benefit and harm is very sharp.
It's a razor's edge, and it's important to remember that patterns of use are influenced by factors like income and nationality, and our sources note that religion often acts as a protective factor against problematic use.
Let's discuss the universal physical challenge of weight management, particularly the middle-age weight gain that so many people experience.
The statistic that quantifies this is pretty straightforward. Adults gain an average of 20 pounds between the ages of 25 and 60.
And why is that?
It's primarily driven by hormonal shifts and a measurable decrease in our basal metabolic rate, or BMR. Simply put, the body just burns fewer calories at rest, and if your caloric intake doesn't drop commensurately with that, weight gain is the inevitable result. #, obesity and weight gain.
This brings us to the classifications of weight based on BMI.
Right. The body mass index, or BMI, is that common measure calculated from your height and weight. A BMI over 25 is classified as overweight, over 30 is obese, and over 40 is severely obese. However, and this is a crucial note from the sources, BMI is widely disputed as a perfect measure of health.
Why is BMI so disputed?
Because it fails to differentiate between muscle mass, which is dense and metabolically active, and fat mass, which can be inflammatory and risky. More importantly, it doesn't account for where the fat is distributed on the body.
And that matters.
It matters immensely. Visceral fat, that's the fat stored deep around your internal organs in your abdomen, is metabolically far more dangerous than the subcutaneous fat you can pinch under your skin. And BMI doesn't capture that distinction at all.
And genetics plays a major role, not just in overall size, but in that fat distribution.
Absolutely. Your genes determine your inherited body shape. They dictate where on the body that excess fat is distributed, whether it goes primarily to your hips, your arms, or your abdomen. While your lifestyle choices determine how much fat is accumulated, genetics guides where that 20 pounds of middle-age gain is stored.
And we should note, linking back to the previous segment, the pandemic accelerated this negative trend.
It did. It led to a measurable health deterioration for many due to reduced movement, stress eating, and neglecting preventative care. #B, protective diets.
So what interventions are effective against this decline? Our sources highlight some specific protective diets, primarily the Mediterranean diet.
The Mediterranean diet is held up as the gold standard because it's not a temporary diet, but a long-term pattern of eating that's been proven to support longevity and metabolic health. It's characterized by being high in whole, unprocessed foods.
What are the primary components of this diet? What's on the menu?
It's rich in fruits, vegetables, nuts, legumes, fish, and whole grain cereals. The key and often the defining element is the heavy use of extra virgin olive oil as the primary source of dietary fat.
And what does it minimize? What are you supposed to avoid?
It is purposefully low in both red meat and dairy consumption.
And what are the proven benefits associated with adopting this type of eating pattern?
The sources show that populations who adhere to the Mediterranean diet have measurably lower overall death rates and a reduced incidence of the common diseases of aging.
And why is that? What's the mechanism?
It's the high intake of healthy fats, the monounsaturated ones, and the antioxidants from all the colorful plants. These create a systemic anti-inflammatory effect, which supports vascular and metabolic function. This means that conditions like type 2 diabetes are much less common.
The sources also briefly mention other targeted interventions for weight management and metabolic health.
Yes, they do. They touch on intermittent fasting, which focuses not on what you eat, but when you eat. This gives the body extended periods without calories, which may promote cellular cleanup processes like autophagy. And they also mention bariatric surgery, which is, of course, reserved for severe obesity and profoundly alters the digestive system to achieve major weight loss and often a reversal of metabolic disease.
We've detailed the physical realities of aging, but now we have to discuss how population health is measured, and critically, how those metrics reveal these profound socioeconomic disparities. The sources provide 4 essential metrics for health assessment, #A, key metrics for health assessment.
The first and the simplest is mortality. And this is just measured by average life expectancy. In 2020, the average was 72 globally, though this varies drastically by nation and demographic.
Okay. The second is morbidity, which is the incidence of disease.
And morbidity highlights a crucial gender disparity. Women have lower rates of mortality, they live longer, but they suffer from higher rates of morbidity than men. This means they generally experience more non-fatal diseases and illnesses over their lifetime.
The third metric assesses our functional independence, disability.
Yes. Disability is typically measured by assessing a person's inability to perform what are called activities of daily life, or ADLs.
Oh, yes.
These are the basic self-care tasks that are essential for independent living. Things like bathing, dressing, eating, and just walking across a room.
And finally, a metric that attempts to quantify our quality of life, vitality.
Vitality moves beyond the simple absence of disease. It refers to psychological measures like happiness, satisfaction, feeling a sense of purpose, what some call flourishing or experiencing flow. It asks the question, are the years of life being lived richly?
To assess the impact of health interventions and inform policy, health economists use 2 extremely complex but essential metrics, DALYs and QALYs. Let's truly unpack what these mean.
Okay, so these are tools for cost-benefit analysis.
Yeah.
DALY stands for Disability-Adjusted Life Years. This metric attempts to quantify the burden of a disease. It indicates how much and for how long a specific disability, let's say chronic pain from arthritis, impairs someone compared to a theoretically healthy lifespan. It's measuring life lost due to morbidity.
Like policymakers use DALYs to see which diseases impose the greatest burden on society.
Precisely. Conversely, QALY stands for Quality Adjusted Life Years. This metric is used to evaluate health interventions. It indicates the quality years added to a person's life because of a successful medical procedure or a policy change.
So a QALY 1.0 would be?
A QALY of 1.0 is 1 year of perfect health. If a treatment adds 10 years of life, but only at 0.5 quality, that's 5 QALYs.
So these 2 metrics allow officials to decide whether it's more cost-effective to spend money on a vaccine that prevents a minor disease in 1 million people or a new cancer treatment that adds high-quality life to just 1,000 people. It guides the really tough decisions about resource allocation.
They force an objective look at health, moving beyond simply extending life to ensuring the life that's being extended is worth living. #BB, correlating income, residence, and health.
Now we arrive at what might be the most critical finding from the source material: the correlation between income, place of residence, and the timeline of physical decline. The data on socioeconomic disparities is frankly staggering, and it's a universal phenomenon.
This is an undeniable truth worldwide. Adults with high socioeconomic status, or SES, they live longer, and they avoid morbidity and disability more effectively than their less affluent counterparts.
And the sources make a crucial point about the limitations of policy intervention here.
They do. This disparity holds true even in nations that have universal health care. The least affluent people still experience shorter lives and higher rates of disease.
So it's not just about access to a doctor.
No, this demonstrates that the root causes of health inequality go far deeper than just access to insurance or clinical care.
So what are the fundamental mechanisms that are driving this profound gap in health outcomes?
Well, they're multifaceted. First is the concept of allostatic load. That's the constant chronic stress imposed by poverty, financial insecurity, and systemic discrimination. It just wears down those homeostatic reserves we discussed earlier.
So stress is literally aging you faster.
It is. Second, lower SES groups often live in what are called food deserts, which increases obesity and poor diet. Third, they're often exposed to greater environmental toxins, air pollution, poor housing quality that accelerate systemic decline.
Let's focus specifically on the U.S. risk disparity because the raw numbers here are just shocking.
The sources are unequivocal. In the U.S., every single health risk, from smoking rates to obesity to hypertension, is more prevalent among those who are below the poverty line. And the difference in mortality risk for middle-aged adults is huge.
Give the striking statistic that summarizes this vulnerability.
The overall risk of dying between the crucial ages of 25 and 65 in the U.S. is approximately 15%. However, for the least affluent groups, those living below the poverty line, the risk of dying in that same age window is nearly triple that.
Triple.
It reaches as high as 50%.
50%. A 1 in 2 chance of dying in middle age. That makes socioeconomic status arguably the most powerful predictor of life and death, superseding nearly every other single factor we've discussed.
It is the ultimate biosocial risk factor. It confirms that the environment, which encompasses your income, your ethnicity, and your place of residence, acts as a potent accelerator of senescence. You can have great genes, but if you live in chronic stress and poverty, the clock just ticks much, much faster. #outro. So, to synthesize what we've learned, biosocial aging is a highly detailed, systematic, and universal process. We have these firm biological markers like the 1% annual collagen loss starting at age 20 and the measurable reduction in oxygen capacity per decade.
The hard data.
The hard data. But the most powerful force shaping the experience of aging is not biology alone. It is the profound interaction between controllable lifestyle choices and systemic socioeconomic standing.
Absolutely. That massive difference in mortality risk based on affluence, the 15% average versus the 50% for the least affluent, that is a powerful takeaway that demands our attention. It forces us to look at the intersection of public health and societal structure.
And tying back to the psychological findings we extracted, particularly within the sexual reproductive system, we identified that distress over age-related physical changes is often more closely tied to anxiety and expectation management than to the objective physical reality.
And that raises a final provocative thought for you to mull over as you reflect on your own physical landscape. If the psychological burden of slower sexual responsiveness can be largely mitigated by adjusting our expectations and improving relationship communication, what other physical changes of adulthood are unnecessarily amplified by societal anxiety, by ageism, or by our own rigid personal expectations? How much of the psychological consequence of aging can we actually control simply by adjusting our perspective and accepting the inevitable change in rate rather than fighting the reality of decline?
The body will slow down, but the mind's reaction to it is, I think, profoundly negotiable.
Thank you for joining us for this deep dive.